Any questions on DKA HHNS?
Wait, I think we did. Amanda, did we figure out, didn't we have a question about the potassium and or did we figure it out?
I think we figured it out. Just looking. Oh, I think we were confused with the levels, but so if it's 3.3 to 5.5, you're giving potassium with the infusion.
Oh, and then if it's below 3.3, we're giving it before. And then above 5.4, we're holding.
Yeah.
Above 5.3. So yeah,
5.3.
Yeah.
Okay.
Above 5.3 and below 3.3.
Okay, and when it says watch for the drop, because we're holding the potassium, when are we going to reassess for that drop?
BMPs are drawn Q2.
Okay.
CMP, BMP, whichever the physician orders, is ordered Q2, and your glucose is ordered Q1.
Okay. Thank you.
So is the BMP only ordered, the blood work's only ordered Q2 while he's on the drip? Once he comes off the drip,
Yes.
do they stop it? Okay.
There's probably like one or two after, once everything is like, once you're bridged to sub-Q, just to monitor for like a last minute shift kind of thing. But it's not going to be as like heavy hitting as it is when the insulin is running. You know what I mean? Does that make sense?
Yeah. Yeah. Okay.
Okay. Good questions. All right. You want your to be less than 12. All right, so we left off on pituitary complication. Oops.
I have a quick question.
Yeah.
So you've taught this class to someone else before, a class before us, right? The complex care 2.
Twice.
Do you still have those, like, because I feel like they would be super helpful. Do you still have the lecture videos, like, on YouTube?
I sure do.
Awesome. So we can review your lecture videos on YouTube for your complex care 2.
Yeah.
Okay, cool. That's all I wanted to know.
Yeah. I don't know if I say anything different though. But yeah, absolutely.
Where do we access the video?
Care too? I already sent all of that to you. I sent you the notebook LM.
Okay, so it'll have, sorry, I didn't look at it.
It has everything. It has every one of my videos. all of the PDFs. It has everything.
Oh, okay. I did not know
When
that.
I went on that
Oh,
link,
that
it
was that
didn't work.
notebook.
Hold on. What?
That notebook thing that's what you sent us? Because I tried
Yeah.
to open that and it didn't it just was like a whole bunch of jumble. Can you resend it to me?
Bunch of jumble?
Yeah, it was like
It was like
wasn't.
codes and stuff.
Yeah,
Yeah.
Yeah.
written in code. Yeah.
Interesting.
Mine was also the same thing. I didn't understand
Open
anything.
for me. Do you guys have an account?
Mine was just blank. Mine was
Oh,
just blank
make an
because
account.
I had a notebook
Yeah,
You might have to have an
downloaded
account,
on my
yeah, because it
phone.
opened fine for me.
Blank.
So I saw everything. I saw all the PDF and everything.
Okay,
When I
you
open-
need to
It didn't
make
work for
a
me.
Notebook LM account.
You said make an account. It'll work if we make an account.
That's what I'm hearing. Yeah.
Okay.
Yeah, it should because I have an account. It's free.
Yes, it is free. Yeah, there's 16 sources. 12 lead EKG case studies, 150 practice EKG questions, ACLS protocol, basic EKG interpretation, burns, respiratory, videos, lectures.
Miss Simmons, I have an account and it still didn't show up for me.
Were you signed into your account?
Yep, I'm signed in right now. Stay logged in.
Yeah, I just went to my email
This-
and tried the link again, and it opened right up to the notebook with everything.
Yeah, this is the link. I just sent it in the chat.
I just got mine to work.
Yeah, me too. I just had to download the app and then I signed in and it worked.
Mine just made me make sure I was signed into my Google account. I don't know if that helps anybody.
So it's working on my laptop and not on my phone. That's weird.
Oh, I don't know. Yeah. Looks like I'm missing some videos too. Hold on.
You won't have plans to take this down too. Step out of line. I need you all.
You drink your shake already? What this is?
We accept your offer. With a fast salary can't free.
Oops.
I believe a more strategic and preemptive approach to leadership is now needed, making me the logical choice. My intellect combined with no. Cecil,
Now, I don't want you guys to be talking about this in class because she's probably going to be mad that I did this. So don't be telling her that I did this. Exactly. I didn't do nothing. And I'm like, why are you letting somebody else teach you when I'm your teacher?
So we're going cardiac next month.
Cardiac, respiratory, ACLS, burns. Okay, so I'm pretty sure I just uploaded all of the lectures. So now, so I don't know if you guys know how to use Notebook LM, but so on the right side where it says studio and you have all these different things, it says audio. Let me share my screen. Are you guys logged in? Let me share my screen.
There. Is it fine?
No, yeah, it will. It'll pop up back there. Okay, so this is, everybody see my screen?
Yeah.
Okay, so this is what you should be seeing, okay? So over here on the left where it says sources, there are like 20 some sources over here. All of these little red, these are lectures, then there's little extra stuff, the PDFs, burns, respiratory, ACLS protocol, all that stuff is all on the left side. In the middle, which is really cool, is it summarizes basically everything. It summarizes everything. So you can say it, and it'll give you prompts too. How to identify and treat respiratory acidosis versus alkalosis. You can click on it and it'll give you a whole chat. It's basic, it's AI. It's AI trying to teach you whatever, all the things. So, and then you can ask whatever questions you want to ask, okay? So then on the right side, this is where it says studio, okay? So right now, there's a bunch of stuff over here, okay? That you can click on, that you can look at, whatever. But now, since I just uploaded more stuff and I'm gonna click on all of these little things and it's going to make a new, each one of these using every single one of the sources, all 23 sources. Okay. So like it says down here, generating infograph based on 23 sources, mind map on 23 sources. You get what I'm saying? Quiz on 23 sources. Now, is this going to be the best thing in the entire universe? Is it going to help you? Is it going to help you? Yes. Should this be your only source of material? No. If it was me teaching the class, yes. It's not me teaching the class. Okay? So remember that and use it as a helper, like a tool, and not your main source. Okay? Does that make sense? Can everybody try to access the link to make sure it works?
You want us to access the one you just put in the chat?
Yes, and make sure it works. Because in 3 weeks, when you're like, oh shit, I can't get this to work, and you're gonna be like, how do I get a hold of Jessica Simmons? You're not gonna be able to get a hold of me.
You didn't have to say that with a smile on your face.
I mean,
Part of it's
honest.
working, but some of mine says it's still generating.
Yeah, there's 4 that are still generating.
Yeah, it's working now.
The slide deck, video overview, the audio, those take a while because they're like super in depth. The slide deck specifically, is a PowerPoint that it creates. I love the slides that it creates. I think they are so cool. I think they really like put all of the ideas together in a concise way. So, and then the audio overview is like a podcast style, which I think is really neat. I mean, I know you're going to miss my voice, so you could totally just listen to my voice. But if you don't want to listen to my voice, you can use it as a podcast kind of thing and listen to somebody else's voice. I will not be offended. Is it working for everyone?
Yes.
Yes.
Okay. All right. Can everybody see my screen?
Yes.
Yes.
Okay. All right. So moving on to pituitary complications. These are two conditions due to the dysregulation of the antidiuretic hormone, which we shorten to ADH. Can also be referred to as vasopressin. Okay, but you're going to hear me refer to it as ADH. So there's two conditions, DI, which is diabetes insipidus, and SIADH, which is syndrome of inappropriate antidiuretic hormone. Okay, so normally the antidiuretic hormone regulates fluid balance and blood pressure by number one, stimulating water retention, and then number two, stimulating vasoconstriction in the blood vessels. ADH is stored in the pituitary and it's released when the hypothalamus tells the pituitary to release it. Okay. So what is the difference? DI, diabetes insipidus, by the way, it does not have anything to do with diabetes. Okay. Please do not get these confused. It has nothing to do with your glucose. Diabetes insipidus can be caused by a brain injury, trauma, surgery, damage to the hypothalamus, a tumor, specifically small cell lung carcinoma, which is odd, very odd. It's a kind of zebra. Why does this small cell lung tumor release excess ADH? I have no idea, but it does. And a central nervous system infection. Basically anything that can damage the hypothalamus or the pituitary and cause it to secrete too much. I'm sorry, hold on. Diabetes insipidus syndrome. I need to make sure I'm not screwing this up in my head while I'm talking to you about it. Okay, so diabetes insipidus, there is not enough, so put a big star, not enough ADH. There is not enough antidiuretic hormone. Diabetes insipidus, not enough. So without ADH to tell the body to hold on to the water, the kidneys produce an insane, I'm not kidding, I'm talking 7 to 20 liters of urine a day output. I've seen one patient in my career with diabetes insipidus, and I was a tech. And I'm telling you what, every 20 minutes that I went in there to look at her fully, it looked like the bag was going to explode. Every 20 minutes. It was insane. I never saw so much urine in my life. Okay. So the urine output is extremely high. If you're putting out all of this fluid, what do you think it's like inside your body? Dry. It's dry inside. So DI, dry inside. Okay? So you are severely dehydrated, which is why your blood osmolality is so high, because it's so thick and concentrated. Your blood serum is thick. You have high serum sodium for the same reason, because it's so concentrated. The urine specific gravity, because the urine output is so high, your urine is severely diluted, which makes the urine specific gravity low. And the osmolality of the urine low, because they're so diluted. Does that make sense? So everything inside is dry, but what you're putting out is so diluted. Okay? So this results in the patient having dry mucous membranes, decreased skin turgor, hypotension because they're hypovolemic, and polydipsia, which is excessive thirst. Because how do you think they're getting enough fluid to put out 20 liters a day? They're drinking like a fish. Okay? They will do anything for fluid. Do you remember the Grey's Anatomy episode where the guy was drinking water out of the toilet? Anybody? No?
I do, yes.
Yeah. This is a good one. Yeah, the guy was drinking, yes, water out of the toilet because they put him on a fluid restriction. And they actually ended up killing him because Alex Karev ordered hypertonic saline. And remember, I told you hypertonic saline should only be given at 25 milliliters per hour for a total of 4 hours before you have to reevaluate labs. And he ordered it for some crazy amount. And the nurse that he gave syphilis to, remember the syphilis nurse? I don't know how I remember all these things. I'm telling you, it's been years since I've seen this episode. Remember the nurse he gave syphilis to? Well, she was the one that gave the order. Yes, the syph nurse. She was the one that provided the fluids, and dude ended up in a hypernatremic coma, and he was brain dead. Which it is BS how nurses are represented on movies and TV shows, because any nurse, first of all, would never give a hypertonic saline to a patient like that without questioning the order. And she was just like, oh, well, that's the way you ordered it. No, that's not how real life works. That's not how nurses work. So anyways, I want you to remember with DI, they are dry inside and they are putting out an insane amount of urine. More urine than you could ever imagine coming out of someone's body. So the treatment, the main drug of choice is called desmopressin, which is also referred to as DDAVP. DDAVP. DDAVP is a synthetic form of ADH. Okay. And it causes the body to retain water and decrease the urine output. We either want to provide a hypotonic solution, hyper, because you would make it worse and they would die, or in the safest way, an isotonic solution. Okay. Isotonic is always going to be your safest route. Okay. Nursing interventions, obviously strict I's and O's. Okay. Daily weights, vital signs, EKGs, electrolytes, and urine specific gravity, safety precautions. This patient will do anything for water.
I have a question.
Is this a lifelong condition? It depends on what the cause is of the diabetes insipidus. Is it an acute cause or is it a chronic cause? So, is it because of an acute brain injury and you are in an acute DI crisis and then the brain heals and you are no longer in that acute DI crisis? Then that would not be lifelong. If this was like permanent irreversible damage to the hypothalamus, which affected ADH secretion, then yes, it absolutely could be a lifelong condition. So it depends on the underlying cause. Somebody had a question.
I do. So does this condition make them like exhausted, tired from do they not sleep well because they're constantly waking up to go to the bathroom?
Probably. I would assume, yeah. Yeah, I would totally assume that that would be valid for sure.
Oh, it's polyuria then, right? That what they're experiencing is polyuria. Or no?
Severe polyuria. Like the most severe polyuria you could ever imagine. Okay.
I followed a nurse at one of the clinical sites, and she said her husband had this, and whenever they
Wow.
leave, what'd you say?
I said, wow.
Yeah, she said whenever they leave, they have to make sure they have like gallons of water in the trunk, like to make sure he stays hydrated. And he's had it like his whole life.
So I would assume that he takes meds either daily or some type of situation with meds because you can't just live this way for the rest of your life. You have to find balance because you're going to have electrolyte disturbances that could kill you, right? If we're peeing everything out, we already know we're hypernatremic. What do you think our potassium is? We're peeing out all of our potassium. So you're at risk for cardiac complications. You're at risk for neurological complications because of the serum sodium, right? So there has to be a safe balance. If this is something that's going to be chronic for this patient, they have to find a way that is safe for them to live. So obviously this man has found a way with the balance of his medications, making sure that he stays hydrated, that he is living as good of quality of life as he can with the situation at hand. So, SIADH, oh, see, I mixed that up. See that? Small cell lung cancer is for SIADH. If you wrote it down for DI, please cross it out. Sorry. Because DI is not enough ADH. SIADH is too much. The small cell lung cancer produces an excessive amount of ADH. Okay. So, SIADH is the syndrome of inappropriate antidiuretic hormone. Causes include small cell lung cancer. Why it puts out so much ADH, I don't know. I don't know the pathophysiology of it. Brain trauma or surgery, a tumor, and CNS infection. So you have the exact opposite symptoms as DI. The urine output is low. The blood osmolality is low. It's diluted. Your serum sodium is low because of dilution. Okay. This patient is hypervolemic. They're holding on to all of their fluid. You have a high urine specific gravity because the urine is concentrated because there's low urine output. and low urine osmolality for the same reason. So we see weight gain because of the hypervolemia. Probably some pretty bad peripheral edema that could, depending on the patient's heart function, could be backing up into the lungs, causing pulmonary congestion, pulmonary edema. Hypertension because of the excess fluid. Confusion and irritability because of the serum sodium. And seizures because of the serum sodium. Okay. Does that make sense? So make sure we know the difference between the symptoms of DI and SIADH. So what do you think our treatment is? Diuresis. Diuresis, yes. So we have 3 treatments. Number 1 is going to be a loop diuretic, like the other name is. Can't say the other name. What is the other loop diuretic that starts with a B? Bumetidine, aka vasopressin antagonist. I forget what this is called. Vasopressin antagonists are called Vaptans, V-A-P-T-A-N-S, Vaptans. They end in Vaptan. So some of the examples is Lixivaptan and Citatavaptan. So they just end in Vaptan. Okay. There's a very small amount of these drugs. So it's not like it's this huge drug class to learn. It's a very, very small select drug class. And it just ends in Vaptan. Okay. V-A-P-T-A-N. And then hypertonic solution. Because of the low serum sodium. Okay. But I want you to remember, you have to be really careful when it comes to the use of hyper and hypotonic solutions.
Simmons, you're breaking up.
Ah, shit. Is it bad? No, DI does not cause small cell lung tumor. That is not correct. The small cell lung tumor causes SIADH.
Gotcha. Thank you.
Mm-hmm. Should I connect to my hotspot, or is it still happening?
I think it's just when you walk around.
Oh, I do like to walk around. Okay. I need to get one of those, like, oh, no, I don't. Damn it. Okay.
No.
All right. So I was saying, when it comes to hypertonic and hypotonic solutions, I want you to remember, why is the sodium the way that it is? Why is the sodium less than 135 with SIADH? Because it's diluted, because of the fluid retention. So what happens when you normalize the body fluid? You're going to see a normalization of the sodium. So, and it's the same as the other way around. With DI, you're hypernatremic because of the concentration. So when you correct the fluid balance, you're going to see a shift, a normalizing shift of the sodium. Is it going to be enough? I don't know. That's up to the nephrologist and the labs, right? That's not my call. But it's important to know that there's a reason why we're not extremely aggressive when it comes to hypo and hypertonic solutions. Because part of the process of treating the person is going to be naturally normalizing the sodium when the fluid balance gets corrected. Does that make sense? Okay. So nursing interventions, it's basically the same as DI, strict I's and O's, daily weights. This one comes with a fluid restriction, neuro checks, seizure precautions. Okay. I don't know what these, I didn't put these videos on here. Do you want to watch the video? Anybody?
No.
No.
Me neither.
No, but if anyone wants a good video recommendation about nurses, Simple Nursing's video is really good because we did that video when I was in advanced farm like 5 months ago.
Perfect. Thank you, Hannah. All right. Any questions about DI versus SIADH before we move on to thyroid? Actually, we should probably take a break. It's 10:20.
Till 2 today.
We're here till 2. It's a long day.
Yeah.
It's a long day.
Oh, gosh.
So let's take a break. 10 minutes. We'll come back at 9:30 or 10:30. And I think I'm going to try to do a test review today. Yeah, we're going to go over exam 1 and 2 today. That's my hope. And it cannot be recorded. Remember, no recording of the
Simmons?
exam review. Yeah.
Is it okay to do the endocrine worksheet handwritten on notebook paper?
That's what I was thinking.
Yes, ma'am.
All right.
Yes, ma'am. Okie dokie. I'll keep doing it. The no lines make me dizzy and I almost fell down the stairs.
She said that's what she said walking in that it's gonna be. But she's having that go sit down.
Yeah, I started out with lined bifocals, so I just stuck with them. So. Okie dokie. So, there are two really big complications of the thyroid. So the thyroid regularly, it regulates the metabolism and growth and development by producing T3 and T4, which is your thyroid hormones. And calcitonin, which moves calcium into the bone. We talked about the thyroid, what it looks like. It looks like a little butterfly, and it wraps around the trachea. And it is very important to know that iodine is absolutely necessary for normal thyroid function. Okay. We don't usually see iodine deficiency thyroid disorders in the US because our salt is iodized. There's iodine in our food. So you would most likely see iodine deficient thyroid conditions in third world countries. But it is important to know that iodine is essential for creating the thyroid hormones. Also, I feel like I was eating crackers. I got cracker dust all over my face. Also, an excessive amount of iodine can kill your thyroid. So they sometimes use iodine as a treatment for hyperthyroidism. So it's an interesting balance of iodine when it comes to thyroid function. So hypothyroidism is low T3 and T4, but your TSH is high. And this is because the TSH, your hypothalamus is saying, hey, there's not enough thyroid hormone being secreted. So your hypothalamus tells the pituitary to secrete more TSH in hopes that the thyroid will secrete more T3 and T4. But the problem is that there's something wrong with either the messaging system or the thyroid gland in itself, where it's not responding to the negative feedback system. And it's the same thing with hyperthyroidism, but the opposite. So there's too much T3 and T4. So the hypothalamus says, hey, you need to lower the amount of T3 and T4 so it lowers the production of TSH. Okay, does that make sense? So there's something wrong with the negative feedback system. A thyroid storm is a medical emergency. This occurs with hyperthyroidism. And this is when a very large amount of thyroid hormones are released at one time in the body. And this can happen from a thyroid removal. So you have all the symptoms of hyperthyroidism, but times a million. Okay, so hyperthyroidism, you're anxious, you're agitated, you're tachycardic, you're hypertensive, you have a high metabolism. But with a thyroid storm, it's getting crazy. Okay, you're severely hypertensive, very tachycardic, a high fever of 105 and greater, agitation and confusion. This is not good. Okay. So your treatment is going to be methimazole, which is the drug to lower your thyroid hormones. Corticosteroids are going to block the making of more T3 and T4. Beta blockers are going to control the tachycardia, possibly do something for the hypertension. And then, of course, we don't want temperatures greater than 105. That's not good for anybody. So we need to decrease the body temperature with antipyretics. Okay. The next one is going to be myxedema coma. This affects those with severe hypothyroidism. Okay. This is also a medical emergency. Severe deficiency of thyroid hormones. There's a very high risk again after thyroidectomy. So removing the thyroid is bad in both ways. Okay. And also this can be caused from abruptly stopping your levothyroxine or Synthroid. So this can be even, I mean, the other one obviously is a medical emergency, but I feel like this one is even worse because it's affecting your airway, and you lose your airway, you lose your life, right? So this one, you have the opposite. You have hypothermia, bradycardia, hypotension, bradypnea, which is decreased respiratory rate, and then severe altered level of consciousness, which can lead to a coma. So if you have a patient that has come in with a myxedema coma, myxedema crisis, make sure that you are ready for intubation. That's a huge, huge thing. Okay. Oh, treatment for myxedema coma is IV levothyroxine. You can give it IV, but it's only for like severe situations. You wouldn't give IV levothyroxine just to anybody. You know what I mean? There is one other thing that I wanted to talk about when it comes to, and I mentioned it on Monday. Remember I told you that the parathyroid gland is like 4 little glands that are inside the thyroid tissue, remember? And I told you when you go in and try to remove the thyroid, it's very important that they leave behind the parathyroid, okay? Very, very important. Because the parathyroid is responsible for calcium regulation. Okay. So if you accidentally remove the parathyroid with the thyroid tissue, you can send your patient into a calcium storm. Okay. Which is also life-threatening. It most commonly occurs after a thyroidectomy. A lot of people, if they're very confident in the fact that they never touched the thyroid or the parathyroid tissue, a lot of people will go home after a thyroidectomy. It's like an outpatient procedure. If they have any question whatsoever that the parathyroid has been injured in any way, they will admit that patient overnight so that they can track their calcium hourly, every 2 hours for like the remaining of that evening and then in the morning, just to make sure that the parathyroid isn't dumping calcium into their body. Okay. It's not as life-threatening as the other two, but it is definitely a big deal. Um, putting my videos from this class into Notebook LM. See if it comes up with any cool stuff for us. I don't know where that box of tissues went. It was over here on Monday when I was crying.
That's gonna hurt. Yeah, my nose is already like so dry. It's insane. Yeah, now I busted blood vessels all over my face. They're broken. I don't know, I'm just not getting, like I feel better, but like.
I bet you had the flu.
I think so too. You have the flu, give it to all of us? No, I did not give it to anybody, and that's a success.
Yeah, I disagree. I've been pretty sick, so
Well, I didn't give it,
just saying.
you were sick. Been very sick too.
I have been so miserable. It's disgusting.
If your body's saying slow down and don't.
My body's saying something. Well, I found out, remember, I saw that CVS nurse and she gave me 5 days of Augmentin, which, I mean, listen, I am not a prescribing nurse. I mean, I know that I teach pharmacology, but like, I don't prescribe. It's not something I do. So when the ENT is looking at me like I'm crazy because I only got 5 days worth of Augmentin, she's like, obviously it's gonna come back. How was I to know that it wasn't inadequate treatment? I was trusting my, the person. So I'm like super frustrated about that. It was not adequate treatment. So now 10 more days of augmentin. Yay.
I went to Stanford. So here's this cough suppressant. It doesn't work.
Mm,
Bye. Bye.
bye.
You'll get over it in like 2 weeks.
Henry still has a cough. And it sucks because he's only 3.5 and he's tall, but he's real thin. Like he's only 34, 33 pounds. And so even if he was at an age where like, you know, because they do it a lot by age when it comes to cough suppressants with kids. But apparently, what am I saying? He doesn't even weigh enough to be able to even consider a cough suppressant for him, which is really annoying.
It always said, still say it. Just take it. Said you made. Also, did you guys get supposed to?
Yeah, but the leprechaun didn't come to my house. Did anybody's leprechaun come to their house?
Said the leprechaun didn't come, and I said, "What are you talking about?" He said they're supposed to come, and there's supposed to be little footprints, and they're supposed to leave you gold coins. I was like, "Never had a leprechaun come to my house, dude." But when he come, I said, "Maybe they come to school. They don't come to your house." And they were like, "He's like, no."
I have never experienced a leprechaun coming to my house.
It's annoying. Just like the elf on the shelf. Don't do it if you don't have to.
Oh, so it's just like the elf. I
It's
just
so
made
annoying.
another notebook LM for this class.
It says, "See, the leprechaun did come to the house and gave you a scarf." He was so mad. He like walks in the house like searching. He's like, the leprechaun had to come. He said, "What did the leprechaun turn the milk green?" I was like,
They have to turn the milk green too?
"Yeah, yes." I was like, "Dude,
Amanda, did you turn your milk green?
No, I put some nerd clusters out and some candy bars. No, I always wait till the last minute and I forget to get the gold coins. And actually, my daughter's STEM teacher, my oldest, they made the traps and she came home one day and I was like, what the hell is this? I have to do this?
That's funny. My kids, they scavenged them. I was super hungry. But like, I didn't say anything until the 5 minutes.
In here. I just shared another notebook LM link.
I'm not, because I can never see anything because the screen's too small. Hopefully when I get my iPhone closed. I said, send it to you guys.
Well, I should probably send it in the email anyways. So let me just do that. I'll do that for you.
Thanks.
Yeah.
Is there a way to save these links like within our account? How does that work?
When
I
you
have
open
no
them, it
idea.
automatically save, Amanda. You'll be able to
Okay.
reopen.
So anytime I just click on this,
If you click
light.
on Notebook LM, it should come up in your notebooks.
Oh, I see. Okay, thank you.
I've been using it for since we were in OB.
Did you?
Oh no, sorry, I'm distracted. Hold on. I suck.
It's okay. We're here all day.
Okay, it's sending. Okie dokie. Are you ready to go over exam 1 and 2?